Hello, my name is Christian von Buchwald. I'm a professor at the Department of Otolaryngology, Head and Neck Surgery and Audiology at University Hospital Rigshospitalet in Copenhagen, Denmark. It's such a pleasure for me to give a talk entitled "In Oropharyngeal Cancer, HPV and P16 Discordance Affect Patient Overall Survival." This is a multi-center, multinational study, and you can read about it in the Lancet issue as shown by the link here. And I'm talking on behalf of the HNCIG-EPIC Oropharyngeal Cancer Group. Thank you so much to my collaborators and co-authors. This is what I have to disclosure. I have nothing to disclosure. On the screen, you can see a photo of my hospital, including the 4 new buildings in front of the main building. And I'm located in one of these buildings when I'm talking to you here. The introduction, I want to tell you that we all know that there's a better outcome for HPV-related or induced oropharyngeal squamous cell carcinomas, which means there's almost a 60% reduction risk of death for these patients. How do we identify these patients? The main detection techniques for HPV diagnosis in oropharyngeal cancers is P16 immunohistology. This is used as a surrogate marker for HPV. And we also have a kind of staining cutoff of 70%, which means 70% of the nuclear and cytoplasmic staining should be positive. On the other hand, we also like to identify the HPV. And the most used method also in this study in more than 80% of the individual cases has been HPV DNA PCR, which is a very sensitive and a very easy clinical and very easy to set up in clinical hospitals as well. If we want to go more directly, we need to go to the E16 and E7, the E6 and E7 HPV messenger RNA RT-PCR method. But the clinical setting of this is quite challenging. Oropharyngeal cancer HPV testing is currently defined by the surrogate marker P16. This is based on the guidelines from the College of American Pathologists and is also based on the HNCIG-EPIC classification edition. And this has a quite importance when we speak about the de-escalation clinical trials, which are performed currently at various centers. But P16 alone as a surrogate marker for HPV causation has been criticized in many studies, including the studies that are shown here on the slide. This is due to a subset of P16 positive oropharyngeal cases are actually HPV negative. And there's only so far a few data regarding P16 positive and HPV negative oropharyngeal cancers. And the data are quite limited in size, and there are no geographic comparisons. So double positivity for P16 and HPV DNA detection might have a better diagnostic accuracy and prognostic value. This is the background, and this is what we have addressed in this multi-center and multinational study. What you see here, that is, we have recruited almost 8,000 individual data from patients with oropharyngeal cancers, and they originate from 13 centers in 9 countries, and which is in North America, Western and South Europe, as you see here. You can also see that especially the contribution from Denmark, which I'm very proud of, contributes the largest portion of the cases. Further on, you can see that especially Canada, it's UK, it's the Netherlands, it's Germany, it's Sweden, it's Switzerland, and it's France and Spain who have all contributed to this trial or study. And you see on the right side of the slide, you can also see the detection methods, and already mentioned it's P16 immunohistochemistry, plus in most of the cases, and also reflected by the amount of testing, that is HPV DNA PCR, which has been the very dominant method for HPV detection. What we found here is that in almost 11% of the P16 positive cases, you have discordance with HPV negativity. And when you look at the various demographic data here, you see here that we have double negativity, P16 HPV negative in 3,560 cases, and we have double positivity in 3,390 cases. In between these, we have discordance group, as already shown here, which is about 289 with P16 negative HPV positive, and P16 positive HPV negative is about 415 cases. And you see here also we have shown the gender, and the men contributes by far the largest, which means almost 3/4 of the cases are belonging to men. Then we have also got data on smoking status. We have got data of tumor subsize. We have the stage, which is according to the 7th edition of the UICC classification. And also shown here on this slide is the treatment modalities. And you see that far most patients have been treated with radiotherapy plus minus chemotherapy. But also more than 10% have had surgery as the only modality. When we look at the results of the various testing, we can see that on the y-axis, you see the amount of the cases where the cohort of the centers showed that there's a double positivity for P16 and HPV as well. On the x-axis, you see the attributable fraction, which means all the centers with their various data outcome in case of P16 positive and HPV negative. What you see is very close relation between HPV positivity and P16 positivity in Canada, which is in Toronto. On the other side, you have the opposite, which is shown by the data from Spain, on the outcome from Spain, where you have almost 30% of cases where P16 were positive, but HPV were negative. In the middle of all this, you have from Denmark and from UK, and you have from France as well, where you see a fraction of discordance with P16 positive and HPV negative between 10 to 15%. So it varies quite a lot depending on the geography. Then we look at the 5-year overall survival among these almost 8,000 patients with oropharyngeal cancers. And what you see is a very characteristic image that you see when the patient is double positive for P16 and HPV, the outcome is significant better than when the patient is double negative or the patient has discordance with P16 and HPV. This is also shown with the adjusted hazard ratio in the table, where you see that the outcome is worse, almost the same, when there's discordance or when in case of double negativity with P16 and HPV. And the cases here only includes locally advanced stages of stage 3, 4A, and 4B. Then we go back and look at the geographical region and the impact of that. When you look at Northern Europe, you see the same pattern. You see that the patients with double positive, they have a much better survival than the patients with double negative and or discordance when they have discordance with P16 and HPV. And the same happens in Southern Europe, and the same happens in Western Europe. As expected, due to double positivity is almost the same as P16 positive plus as same findings there. You see you see a similar survival for patients with double positivity or P16 positive alone. But there's only a very few cases of P16 positive plus HPV negative. So there's not much to do statistics on in this case in Toronto. Then we address the importance of the significance of tumor site. We all know that far most cases of oropharyngeal cancers They are located in the base of the tongue or in the palatine tonsils, but we also have cases representing other oropharyngeal sites. As seen here on the curves, on the figures, you see again the same pattern. You see that the double positive cases with P16 positivity plus HPV positivity, they have a much better prognosis compared to the discordant situations or when the patient is double negative. And that's exactly the same image you almost see for the base of the tongue and the palatine tonsil. And it's almost the same as you see at squamous cell carcinomas located at other sites in the oropharyngeal areas than the palatine tonsil or the base of the tongue. So we see similar patterns for this. But we also want to address or look at the importance of smoking. And it's quite interesting to see here that in a case where the patient or the cohort represent P16 positivity and HPV negative smokers, they have, and are smokers or current smokers, they have the same outcome as in case of they were P16 negative and HPV negative. It's quite interesting to see when we divide the patient of never smokers, we find that the cohort of P16 positive, HPV negative never smokers, they have almost the same, or they have the same prognosis as patient of never smokers that are P16 positive and HPV negative. So allow me to reach the conclusion and perspectives of this multi-center and multinational study. So we find that discordant P16 negative and HPV positive and P16 positive and HPV negative has a significantly worse survival than double positivity oropharyngeal cancer patients, especially if they have smoked. If you're using P16 immunostaining alone, almost 11% of oropharyngeal cancer patients would be incorrectly classified as HPV-related, induced, or mediated oropharyngeal squamous cell carcinomas according to the TNM classification 8. And they actually have a poor prognosis. So risk of misclassification, particularly in regions with lower attributable fraction of HPV, it has to be addressed when you want to design or perform de-escalation in clinical trials, and it also has to be addressed in cases where you need to have an accurate prognosis, and it also need to be addressed in cases where treatment selection, if the time comes. So our conclusion is that we recommend you to look at a cohort of your own region, and if 10% consider double testing, especially if smoker. Thank you very much. I hope you enjoyed the lecture.